Very good morning. Okay. All of you have got this contraception revision, is it not? So you have received your part one. Part two is I will finish it today. It's little again, I have to type everything, is it not? So it's taking some time. So was this useful for you people? Is it in any way useful for you in revising? Okay. This is about your contraception part one. So in contraception part one, what I try to show you is certain important points that you have to definitely know to answer your questions. Okay. See, sometimes not everything we try to complete. Okay. If you're not getting something from what we have given, don't panic because you know something about the topic. Try to rule out the options. That is another way to solve the question. Okay. Please remember because it's a very, you have 19 subjects, is it not? We cannot be expecting I will read obstetrics completely or I will read medicine completely or read pathology completely. Then I will go for the exam. That is not going to be possible. What are you doing now? You're revising all the important topics. Okay. One such topic is a contraception, even from PSM part or from a obstetric part. Contraception is a must question, either as a straight to image based questions, or you can have like a case scenarios or a direct questions. Okay, that's important. Okay, so that's why I've given you one set of questions. Okay, one part of your contraceptives I have completed here. Okay, so I've completed, I'm left with only the oral contraceptive pills, that is the combined oral contraceptive pills and POPs. Otherwise, everything else I have given you, and the remaining is the what are the newer contraceptives. Newer contraceptives that you have to know. Okay, and that is the remaining part that I will be sending it today. Okay. And as we know, ectopic pregnancy is also a very, very anticipated question. So you have to know very well of ectopic pregnancy, everything about an ectopic pregnancy. As we know, it is only we have a very short time to revise. So we'll quickly revise. How do you revise it? So if I've given you this, you should know which is the most common site, which is a fallopian tube, non-tubal site, which is the most common site. It's a ovary. Corneal pregnancy is the ectopic isthmus of the tube, okay, which is involving the isthmus of the tube. What is heterotropic pregnancy? Where you have an intrauterine as well as an ectopic pregnancy in coexisting of both the intrauterine as well as an ectopic pregnancy. When there is a maximum risk, see, you have to get this right. When do you say maximum risk is the history of any previous ectopic pregnancy or a tubal surgery, which is a most common cause of an ectopic pregnancy. Please remember, it should be a PID. Okay, there's a lot of confusion. Okay, so most common cause is the infection. Okay, ectopic pregnancy cannot be the most common cause because not everybody will be having a previous ectopic. Even the preemie are more prone for developing an ectopic pregnancy. Okay, not everybody are going to get to have a tubal surgeries. These are increases the risk of a ectopic pregnancy. Okay, so that is one thing. Similarly, in ectopic pregnancy of the tube, the longest survival should be in the interstitium. Okay, which is the shortest survival. If I say longest, then which is the shortest? So shortest should be in quickly. We are not studying now. We are just revising. Come on, you have to be joining, answering in this. Put it in a chat box or you can unmute yourself and give the answer. Isthmus. Very good. Thank you. Highest risk of ectopic pregnancy is with the history of. That's what I'm saying. History of again, the sentence is highest risk of ectopic pregnancy with the history of previous ectopic will be your first option. If that is not there in your options, then second should be your previous tubal surgeries. Okay. The most common risk factor or the most common cause is going to be a PID. Okay. The maximum chance of ectopic pregnancy with the contraceptive agent. See, any contraceptive agent is not going to be a risk factor, but failure of any contraception going to be a risk factor for developing this. So, tubectomy failure and IUCDs and POPs. Okay. Ring of fire appearance is seen in an ultrasound. What other ultrasound findings you have to remember? Which usually we forget. Ring of fire, everybody knows. I have given the image here. This is what you can expect, this kind of questions. Bagel sign, donut sign, all these are the, again, the ultrasound findings. What other things, important findings you have to remember when ultrasound of ectopic? Empty uterus with a gestational sac with or without a cardiac activity, a complex adnexal mass, a bagel sign or donut sign. So, knowing all this, what else you have to know from this is how to go about with your questions. Pregnancy of unknown location. So the whole of your ectopic pregnancy chapter or your approach to a question will be from this. So this you have to be very, very clear. Your question will contain, basically today we are discussing how to approach the questions. Okay, one such question you should know is your ectopic pregnancy. I'll finish this, then I'll give you a scenario I want all of you to answer. A patient comes to you in a very early gestation, in the sense 6 weeks, 7 weeks of amenorrhea with her UPT positive and with vaginal bleeding. Okay. The first diagnosis will be ectopic pregnancy. Okay. Without any ultrasound, without any other thing. The first diagnosis should be ectopic pregnancy. If the vitals becomes unstable, then you label her as ruptured ectopic pregnancy. Now the scenario is saying that the vitals are stable. So we have a time to do an ultrasound. So we are doing an ultrasound where you could see a gestational sac in the uterus. Then it becomes an intrauterine pregnancy. The scenario changes when you see the uterus is empty, where the adnexa should be checked. The gestational sac is seen with the cardiac activity in the adnexa. When I talk about adnexa, it's the tube and the ovary constitute the adnexa. Okay. So gestational sac with cardiac activity is seen in the tube. That becomes an ectopic. See, why do you see in the uterus? That becomes an intrauterine pregnancy. It's you see in the tube or in the ovary. Again, that becomes an ectopic pregnancy. These both are straight, clear cut. Okay. They'll not ask you very straight, clear cut question. They will ask you, I did a scan. Even after that, they couldn't see any gestational sac or cardiac activity. What is your next step in the management? That becomes your question. So your next step should be beta HCG. Okay. Then next question, what you can anticipate, what is a critical titer? Okay, critical titer for a transvaginal, previously it was 3,500. Now it is 1,500. Please fix in your mind. And for a transabdominal scan, it is 6,000. Okay, so this is what is your next management. After doing, when do you expect for any pregnancy or ectopic, everything we see for the doubling after 48 hours. Okay, so you get it below less than 1,500. Okay, it's not this is a previous value, it is 1,500. Repeat it after 48 hours. If you have a decrease in the beta HCG, it's said to be a early pregnancy loss. Okay, that's why you're not able to see the ectopic or you are not able to see any gestational sac neither in the uterus nor in the tubes. If it's doubling, that means it's a very, very early pregnancy that it is going to develop intrauterine. If it's becoming plateauing, okay, that becomes a diagnosis of a ectopic pregnancy. Okay. But you have a critical titer above, still you have an empty uterus. When I say critical titer, at that critical titer, you should definitely see the gestational sac. So if you are not able to see it, a critical titer, above critical titer beta HCG and still the empty uterus, then do a DNC. DNC, if you have a chorionic villi, that means it's an intrauterine pregnancy. If you don't have an intrauterine pregnancy, it becomes an ectopic pregnancy. Okay? Understood? So this will be your approach for the question. So this is a very, very important question. for your whole of ectopic, this is what they anticipated question. What will you do next, according to whatever scenario they're going to give you? Okay, any doubts? See, ectopic pregnancy, all this, you should not have any doubts. You should be very clear cut with your answers, and you're not supposed to miss marks in these type of questions. Okay. Coming to the management. Management is simple. Okay. A patient presenting with amenorrhea Ectopic was to be in shock. First diagnosis, your ectopic pregnancy. What will you do? It's an obstetric emergency. Okay. You take her. If they ask, what is the first treatment that you give? The answer should be resuscitation. What is the definitive management for this? That becomes your laparotomy. There's no thinking of doing a laparoscopy if the patient is presenting in shock. So you directly open up her. That is called the laparotomy should be your answer. Okay. Open self-injectomy. See, opening of how do you open the abdomen? That becomes your answer. Okay. Laparotomy is how we open it. What surgery we do? Either we do a self-injectomy, self-ingostomy. That is different. Okay. The opening procedure will be your first question that will be asked in a ruptured ectopic pregnancy. When the same thing applies to an unruptured ectopic pregnancy is what? Hemodynamically stable. So you can open up with a laparoscopic where you can use do a self-injectomy or self-ingostomy accordingly. Okay. Similarly, you have to know when do you have to expectant management and medical management. Expectant management when you do when the gestational sac is less than 3.5 centimeter without any cardiac activity, serum beta HCG level is very below the critical titer, that is less than 1500, and they are ready to follow. These patients are expectantly managed. Okay. But here, I don't think in India we do anything expectant. We admit them and we monitor. Okay. Medical management is hemodynamically stable. Serum beta HCG is less than 5000. This is very important criteria for a medical management. Which is the drug of choice for medical management? What is the drug of choice for the medical management? Methotrexate. What are the drugs you have to know? What are the other? Quickly, what are the other drugs that you know other than methotrexate? Come on, guys, fast. What are the other drugs you should know? You have to remember KCL. What are the other drugs? KCL, okay. See, I think you should be knowing this chart always. What are the other drugs used in the medical management? It should be methotrexate, prostaglandins, PGF2, KCL, most of you are knowing. What other things you always forget is your actinomycin D. Even the mifepristone can be used, even vasopressin, hyperosmolar glucose. All these are the things that you have to remember. Okay. What is the mechanism of action of a methotrexate? What is the mechanism of action? It inhibits the trihydrofolate reductase, thereby inhibiting the DNA synthesis. When I say inhibiting the DNA synthesis, it actively growing cells are killed or inhibits its growth. Okay, that is very important thing you have to remember. Okay, what other things you have to know? What are the regimes you know for an ectopic pregnancy? You have a single dose regime, 2-dose regime, and a multiple dose regime. What you should know for your exam point of view, at least the names you have to know. And what is the dose of the drug is very, very important. When I have to talk about the single dose regime, it is 50 milligram per meter square. Even the 2-dose regime is 50 milligram per meter square. Whereas a multiple dose regime, remember, it is 1 milligram per kg IM with a folinic acid, 0.1 mg per kg should be your answer. How can they frame questions for you? Dose of a methotrexate in a single and multiple dose protocol for an ectopic pregnancy. It's a simple question if you know what are the doses. Is it not? So this is a very, very important. And always what we get confused is your surgical management. Self-injectomy means you're removing the part of the tube. Is it not? So this tube cannot be restored. Ruptured. If the tube is ruptured, you're not going to sit and restore there because it's going to the patient will be presenting in shock. So the affected tube or it has to be taken out. So that is called the salpingectomy. Salpingostomy means you are making a hole. Gostomy is nothing but a hole. You're making a small linear incision in the antemesenteric border and extrude the products and leave it unsutured. It is called salpingostomy. When I say salpingotomy, is nothing but the same thing, the same procedure, except for that you close with a delayed absorbable suture. What are the other methods you have to know? Segmental resection and anastomosis, milking of the tube. Okay, so this is about ectopic pregnancy. Similarly, direct questions can be, what are the criteria? They have asked n number of times in NEET, what are the criteria for an abdominal pregnancy? It is Tudy-Ford's criteria. Okay. Ovarian pregnancy, it's Spiegelberg's criteria. For cervical, it's Rubin's. It's also called Palman-Ek-Illen criteria. Okay. And heterotropic pregnancy, that we know there is a coexistence. Cervical pregnancy, you should also remember, gives a lantern appearance. Okay, so these are the certain questions they keep on asking in NEET. Okay, Tudy-Ford's, Spiegelberg's, Rubin's, or Palman-Ek-Illen criteria. All these are the other sites. Ectopic pregnancy are the other sites. Okay, all these are direct questions. Now, this was letrozole aromatase inhibitors. Very good. Many have answered. Now, so this is one important topic. So this we have quickly revised it. So don't make a mistake in that. Okay. Now, I'll give you a scenario. I just want to know your level of understanding in ectopic pregnancy. They might not ask you this complex, but still, okay. A patient presented with amenorrhea, say 7 weeks, with her UPT being positive, she comes with vaginal spotting. Okay, but patient spotting, bleeding, patient will not say. They will directly give you in a question as vaginal bleeding. For vitals, as soon as she did, vitals are stable. But in ultrasound, there was a collection in the pouch of Douglas that I could see. Okay, and the diagnosis was more likely of an ectopic pregnancy. Okay, since there was a collection, so she was taken for a laparotomy. Since there was a collection that we could directly see in an ultrasound. What is your likely diagnosis in likely diagnosis? Your options are ruptured tubal ectopic pregnancy, tubal abortion, unruptured ectopic pregnancy, ovarian torsion. What is your answer? What is your answer? Okay. Good. Some have given, most of you have given the answer as B. Whoever has given answer B has a good understanding of that, not to worry. See, when I say ruptured ectopic pregnancy, and the question says her vitals are stable. Please note these kind of subtle or the very key features they give you. This is the hint for you. The vitals can never be stable in a ruptured ectopic pregnancy. So definitely, please remember, this cannot be your option. Ruptured cannot be your option. That is ruled out. Next is about your unruptured. Yes, it can be unruptured. Without unruptured pregnancy, still you can see collection in POD. It's rare. So that's how this is ruled out, and ovarian torsion is also ruled out. You're left with the option of tubal abortion. Yes, tubal abortions their vitals will be stable, it would have aborted, and all the bleeding would have settled in a dependent area, that is the POD. Okay, this kind of questions is very much anticipated. This is because the small question itself will give you the answers. Read the question carefully. Is it not? So these are the keywords. I have told you n number of times the vitals are unstable, but you miss that point of being given there the vitals are stable. Okay. Read it very calmly, because if you know our answer, okay, when you know a particular question, you know that topic very well, then you have to be 100 more careful than the other questions. Okay. Concentrate on what are the important things that they ask you, especially repeat type of questions. Okay. Okay. This, what is this procedure? It's an old procedure. If they ask you, see, what is this? Photosynthesis. Is it done nowadays? No. Okay. Seldom done. Okay. Now, there's one more question that you have to know. A 30-year-old presents with a pain abdomen. Okay. And a history of amenorrhea since 1.5 months on ultrasound is shown in the picture. What is the probable diagnosis? So, if they ask you a question, a patient, a 30-year-old pregnant woman who is giving a history of 1.5 months of pregnancy with pain abdomen, they have not given something to do with, yes, it's threatened abortion. Okay, it is threatened abortion. Okay, but what have they given here? This is the uterus with the cavity they are showing you. Okay, and this is a free fluid. It is nothing to do with an ectopic pregnancy. They are not displaying anything of the tube. Okay, that is one important thing. How will you identify the tube if they give an ultrasound picture of a ectopic pregnancy? So this one image is a very, very important image that you remember. Ring of fire appearance. See, you can see multiple cysts. Whatever the tube itself, you can see these are the small cysts that is displayed. This is a part of the tube. And you can see the tube is like this, and they have shown you this. Okay. All this, whatever smaller cysts are seen as that will point out towards your ovary. Okay. These kind of questions and how to approach is a very, very important thing. Okay. That is called the pregnancy of unknown location. This topic I have chosen because it's a very, very important, and definitely you can expect a question from this. Okay. Similarly, of contraception. Next, many people have asked for the all these oncology part. Okay, oncology part also I made it in a shorter tabular formats for you people to revise. I will be sending it today. Okay, it is taking some time because they have to make again enough tabular format. Yes, I know it's your exams are approaching. Try to give you as early as possible today. Okay, today the other part of contraception 2, part 2 also I will send you. We'll complete the contraception, and we will also I thought of doing another session oncology, as you have asked already. Another very important newer aspect is your aneuploidy screening in pregnancy, because this time there was questions from screening in INI-CT. So definitely you have to have knowledge of this screening in pregnancies for your NEET exams also. So the topics might repeat in your NEET. Whatever INI-CT they have asked on screening, in the sense they've asked what is they given a quad test, which was a high risk for trisomy 20, high risk for neural tube defect. Is it not? There was a question. So what is your next step? That was a TIFA that we have to do for neural tube defect, which we can identify by ultrasound itself. Okay. What is wrong? Who has not received Varsha? Okay, Varsha, we'll be sending it to the main, this one. All of you who have not received will get it, okay? Not to worry. Okay, and this is one important thing I think you had to revise. Another one is your types of abortion. Abortion also have a lot of questions they keep on asking you. Okay, so it is important that you people have to. What are the types of abortions? Spontaneous, induced, and recurrent abortions. When do you say it's a recurrent? Two or three? Give me answer, two or three. When will you start investigating the patient? With two or three? That becomes your next question. With two. Good. Okay. Just that this is a quick revision that you have to know. It's a most common for the first and second trimester spontaneous abortion. Remember, it's a aneuploidy should be your first answer, followed by the trisomy and the monosomy. Okay. Monosomy X, which is the most common cause of recurrent abortion. First is a septate uterus. If I have to say most common cause for the first trimester abortion, it should be an APLA. Okay, recurrent first trimester abortions, the most common cause is idiopathic, followed by that is you always investigate for your immunological disorders. That is specifically to mention, it's a APLA. Most common chromosomal anomaly that is associated with recurrent abortion, please remember it's a balanced translocation. Most common cause of a second trimester recurrent abortion is cervical incompetence. Immunological cause for a recurrent pregnancy loss is APLA, as I told you. What is the role of infection in RPL? Only infection that can lead to recurrent abortion is syphilis. Okay. Infection that can lead to spontaneous abortion but never lead to a recurrent abortion. Okay. Therefore, torch testing is not done routinely for all the patients. If they will definitely ask you torch testing for a RPL, torch testing for a RPL is not recommended. Okay. And what else you have to know is the types of abortion. How will you identify? There are a lot of confusions with this. Not to be, see, it's just application. Okay. If what is the difference between inevitable and incomplete? They always get confused for this. Is it not? So inevitable means still the pregnancy is inside, the process of abortion has started, and we cannot be giving an injections or giving any kind of medications. We cannot stop that abortion. That is what is called as inevitable. Okay, the os is open here. The height of the uterus may be equal to corresponding, or it can be less than the period of gestation. But an incomplete, you will definitely get a history that passing of a mass or they're passing a clot with a severe pain with bleeding. Whereas an inevitable, they might be having just spotting PV with pain abdomen. Here, they have to pass. It's almost in a process of abortion. They've already passed a amount already. That means a part is inside and part has already they passed as a clot. So definitely the pain with pain abdomen with bleeding with the passing of mass will be present. Height of the uterus will definitely be less than the period of gestation and the internal os will be open. Why? Because the another part is still remaining inside. So the os will be open in this. So inevitable and incomplete, don't get confused. With complete, everything has passed. They will give you a history that they passed a mass. With that time, they had a severe pain and bleeding. After the passage of the mass, the pain as well as the bleeding has subsequently or significantly reduced. So the internal os will be closed. Okay, that's how you differentiate between incomplete and complete. What do you mean by missed abortion? Missed abortion, they might not have any presentation. By doing an ultrasound, you can see that there was no cardiac activity. Okay, even at 12 weeks, if you're doing a scan, for example, we are doing NT-NV scan and suddenly we could not locate this heartbeat. Okay, you can see there is heartbeat is absent. That it becomes a missed abortion. Okay, here height of the uterus will be corresponding to the period of gestation, internal os, everything will be closed. Just in the ultrasound, you can see the cardiac activity is absent. Okay, what is a very important thing that you remember, ultrasound feature that you have to remember for a threatened abortion? What is that finding they often mention? That indicates it's a threatened abortion. It's a subchorionic hemorrhage. Subchorionic hemorrhage, a subchorionic collection. All this point towards your threatened abortion or a inevitable also you can see. Okay, so mostly we take it for a threatened abortion, especially if there is a subchorionic hemorrhage, provided the os should be closed. That I told you, that's how you differentiate between a threatened and an inevitable. Okay, and inevitable with the incomplete and incomplete with the complete. Okay, any doubts in this? It's a very, very simple question. It's about how you apply it. Okay. Any doubts in this? There should not be any doubts in this because this is also an anticipated question. Simple question. Okay. There's something called the FIGO 2023 charting. Just read once. Okay. They are not going to ask you what is the dose, how much you have to give. Okay. It's about how they give. Basically, how they give. That's what is important. How do they give you? Any idea? Less than 7 weeks, more than 7 weeks. What is the dose that you give? We usually give it as Mifi and Meso combination. Mifepristone followed by a misoprostol. Okay, that is what is the combination that you have to know. What else you have to know is MTP amendment. Okay. Yes, Mifi and Meso combination. Okay. MTP amendment of 2022, what you have to know. I'm not given much more things. I've just given what are the important amendments have been made. MTP can be done till 24 weeks, which was previously 20, now it's 24 weeks. In case of any contraceptive behaviors, MTP is done till 20 weeks only. Okay. In severe congenital anomalies, see, sometimes the anomalies, not all anomalies are detectable within 24 weeks. Some develops later, like in a cardiac anomaly. Severe cardiac defects most of them are diagnosed in your second trimester, that too after 24 weeks. In those cases, what is that they have kept is there is no upper limit, but the parents have to apply in the medical board. Okay. Apply in the medical board for the termination. Who are these medical board? The medical board consists of a gynecologist, pediatrician, radiologist, and person from the state. So they are the person who are going to give approval for the termination of these kind of severe congenital anomalies of the fetus. Even if you have to say if it's 26 weeks, 27 weeks, 30 weeks, you have to apply in a medical board. Even 24 plus 2 weeks, they have to approach the medical board. Okay. The single doctor opinion till 20 weeks and 2 doctors' opinion is needed, especially if the termination is required, if it's in the around 22 to 24 weeks. Okay. What is a qualification to do MTP? You would have read n number of times, but just I have given it, read it once. Okay. If it's less than 12 weeks, at least the registered medical practitioner should have assisted 25 MTPs, or they should have at least done 5 MTPs on their own. Okay. MTP between 12 to 20 weeks, they have to do, they should have an internship in obstetrics and gynecology at least 6 months, or they should have an experience of 1 year in any hospital. Okay, with all the facilities, and provided they should also have their diploma, degree, DNB in obstetrics and gynae. And there's a confusion with this MVR syringe and the menstrual regulation syringe. Okay. See, MVR syringe or menstrual regulation syringe, all this is used in places like in a PHCs where there's no requirement of any current or power supply there. Usually, they connect this with the MVR syringe with a Carmen's cannula. That how will you decide the size? Based on the size of the uterus, you use the Carmen's cannula. Is it not? So, what is your questions can be is MVR syringe and menstrual regulation syringe. MVR syringe is 60 ml and menstrual regulation syringe is 50 ml. Here you have 2 valves and here you have 1 valve. The pressure that you used here is 600 mg, that the pressure that is created. Your Carmen's cannula is connected here. Okay. And fitted with a Carmen's cannula and suction evacuation is done. Okay. And always asked question from this one is, what are the first trimester method? What are the second trimester methods you have to know? Medical methods. I know everybody remembers mifepristone, misoprostol. Okay. The things that we always forget is your methotrexate can also be used for first trimester abortion. Another one is your tamoxifen. these are the two drugs that we always forget. When I used to forget, that's why I'm mentioning Mifi and misoprostol. I'm not gonna tell, but these two drugs also you have to keep in your mind that it can be used for your first trimester abortions. Now coming to the surgical methods, please don't get confused for dilatation and curettage, dilatation and evacuation. Curate is just your curating and taking out the retained products. When I say evacuate, you are taking a large chunk of the parts of the fetus from inside. Okay, that is evacuate. Okay, and surgical, remember menstrual regulation, manual vacuum aspiration, suction evacuation, dilatation, and curettage comes under your first trimester. Dilatation and evacuation using a forceps, ovum forceps, can be done until 15 weeks. Okay, and that comes under your second trimester. They usually ask for the dilatation curettage, dilatation evacuation, which comes under, don't get confused, curettage is in the first trimester. What are the drugs that is used in the second trimester? Prostaglandins, misoprostol, even the carboprost is used in your second trimester. This is one thing, again, we tend to forget. Okay. Dilatation and evacuation using a ovum forceps until 15 weeks. Okay. Intrauterine installation of hyperosmotic solution or hypertonic urea, saline or extra amniotic, ethacridine lactate or prostaglandins, all these comes under your second trimester. Oxytocin infusion and hysterectomy, of course, it comes under your second trimester. Okay, this table have to be remembered properly. So we have completed two major chunks. That is your ectopic pregnancy. Another one is your abortions. Okay. Another important thing that I want you to know is postpartum collapse. See, because I've seen so many papers that they keep on asking you this kind of questions. How to approach these questions. Postpartum collapse. As soon as then you realize the question is around this postpartum collapse, first see what the question is. Approach in your question should be in a very stepwise sequence, in the sense, see what is the vaginal bleeding. If the vaginal bleeding is present, and the question says the uterus is relaxed, fundus is palpable above the umbilicus, the answer should be a atonic PPH. So that question is towards your atonic PPH. Okay. But if they add in your same question itself, the atonic PPH is not responding to uterotonics. Next, well, the option it should strike in your head should be genital tract traumas or any retained placenta or retained tissue inside. Okay, that's how you go. Okay, if this question says the uterus is well contracted, then they are pointing towards your genital tract traumas. Okay, if the same question that was for the vaginal bleeding is in a significant amount is present, if they divert your question saying that the vaginal bleeding is normal, that means there is a bleeding, but that is lies within your normal limit. For a normal vaginal delivery, 500 ml is normal. Okay, but the bleeding is normal, but there is a hypovolemic shock, in the sense there can be hypovolemic shock only when it occurs there is excessive bleeding. Okay, but this is for another scenario I'm telling. This you leave. Second one we will concentrate. The bleeding is normal. Initially it can be normal bleeding, but the patient presents with bradycardia. That means they presents with a neurogenic shock, and the per abdomen fundus is not palpable. The answer is very straightforward, it's uterine inversion. In uterine inversion, it need not be a hemorrhagic shock. They might present with a neurogenic shock. That's how they present with a bradycardia. Later, they might become a hemorrhagic shock. The first presentation is a neurogenic shock. So, uterine inversion. So, the question is towards your uterine inversion. Per abdomen fundus is not palpable. It's confirmatory that the question is on the uterine inversion. In uterine inversion, what else you have to know? What are the methods? First method, second method, third method. What is your first method? Come on, that's how we quickly revise. What is your first method you do? As soon as hydrostatic method. Is it hydrostatic method? Will you not manually try to replace it? First thing is, if the placenta is attached with the uterus, never remove the placenta. Removing the placenta will lead to torrential bleeding and we will lose the patient. Next is your manual replacement. What is that method called? First, you will use the manual replacement. What is that method called? Reposition. Yes. Reposition the uterus. What is that method called? Come on, guys. What is that method? Johnson's method. Ramya, thank you. Next method will be your hydrostatic method. Hydrostatic method, its full form is hydrostatic O'Sullivan method. Sometimes they ask you O'Sullivan method. That is nothing but the hydrostatic method. Next, what else is there? You have the surgeries. Surgeries you have to know abdominal and vaginal. Just the names. Okay. That table also I'll be adding here for the uterine inversion in a short. Okay. So that is about the uterine inversion. This is for your approach I'm taking. Okay. If the same question says the bleeding is within normal limit, there's a sudden onset of breathlessness, cyanosis. Please note what I'm talking. Breathlessness, cyanosis, there is hypoxia and the signs of heart failure. That answer, don't go and give the answer as amniotic fluid embolism. It is pulmonary embolism. If you have a signs of heart failure, cyanosis, hypoxia, cyanosis, okay, that becomes your key here. Similarly, signs of heart failure, that point towards your pulmonary embolism. Okay. In the question, if they say during delivery or within 30 minutes of placenta delivery, patient develops sudden onset of hypoxia or breathlessness, okay, no other features of because of any bleeding, okay, then the answer becomes your amniotic fluid embolism. Okay, what is this criteria for amniotic fluid embolism called as? Clark's criteria. Okay, there is no fever in this, no fever, no signs of infection, no DIC. DIC might develop later. That is because of an amniotic fluid embolism, not because of an hemorrhage here. That points towards the answer of an amniotic fluid embolism. Similarly, you initially there was not much bleeding. Later, bleeding might be normal. Still, you see a hypovolemic shock. Okay, but uterus is well contracted. They complain of severe perineal pain and not able to pass urine. Think of an hematoma, genital tract hematoma. Okay, the answer should be your genital tract. You're not bleeding, you're not seeing the bleeding outside here. They are collecting inside. That's why uterus is well contracted, but they complain of a severe perineal pain. See, and not able to pass urine will be the very, very first. Even the perineal pain, they will not able to describe it because many patients think it's normal after vaginal delivery. This pain is normal. That's what most of them think. But the problem arises when they're not able to pass urine. No, they have an urge to pass, but they're not able to pass urine. So the answer should be clear-cut genital tract trauma. Especially if your question says the uterus is deviated to one side, please think of a broad ligament hematoma. Okay, this is what you have to remember for the approach for a postpartum collapse question. Okay, most common cause is your PPH. Don't forget your basics. Most common, you always keep it. Okay, then how will you approach each step? That's what I have explained to you. Okay, any doubts in this? Any doubts? No? Can I proceed? Next is your PPH. PPH at any cost you have to know, is it not? It's you have to know little in detail what should be done first, what should not be done, everything. How will you differentiate between, see, amniotic fluid embolism is called as the Clark's criteria. What does the Clark's criteria say? See, specifically, how will you see? When I say pulmonary embolism, they have signs of heart failure. They present with cyanosis. That is one feature that is pointing towards your heart failure. Cyanosis will you see in amniotic fluid embolism? If you ask me, no. The presenting features will be more like a heart failure. Okay. That is what is an important thing that point towards a pulmonary embolism. Same basics that you apply in a medicine only. Pulmonary embolism, how do they present? Just because in obstetrics, it doesn't mean different, okay? But for amniotic fluid embolism, why is it, how will it differentiate is, that's why you have to stick to the criteria, Clark's criteria. What is a Clark's criteria say? During delivery or within 30 minutes of placental delivery, if the patient develops sudden onset of hypoxia and dyspnea, breathlessness, okay, with they were previously completely she was normal and sudden onset and there is no signs of any pph, okay, no signs of any pph or blood loss anywhere, still she develops all these things, clear cut it is an amniotic fluid embolism. Because amniotic fluid embolism, it's not very easy to identify. If you're identifying and by the time you resuscitate, most of the patients will lose their patient. Pulmonary embolism is little easier to identify than that of amniotic fluid embolism because they will suddenly present with a cyanosis, okay, and similar features of hypoxia. But here are more of a heart failure type of symptoms they present in a pulmonary embolism. Okay, that is what is a key here. Okay, and definitely your question will contain within the delivery of the placenta. That will point towards you. That they should give you. Okay. And next important thing they keep on asking is your PPH. PPH I'm not going to detail, but what you have to know is primary is within 24 hours, whereas secondary is 24 hours up to 12 weeks. That's what you have to remember. Okay. What is fourth trimester? This is a new addition in Williams. Come on, answer this. What is fourth trimester? Anybody? This is a newer addition in Williams, so they might ask you this question. 6 weeks postpartum? It's 12 weeks. Telemedicine is right. It's 12 weeks postpartum. Okay. Why is this 12 weeks postpartum has come up now? See, most of the conditions, see, an initial visit, see, up to 12 weeks. 12 weeks postpartum is called the fourth trimester. Okay. Fourth trimester, 12 weeks postpartum. One is your secondary PPH you can diagnose there. Okay. Some patients think it's a normal to have a bleeding. How much is a normal? Most patients doesn't understand. Okay. That's why I've come up with something called this fourth trimester. They give the initial visit after 3 weeks of delivery. Okay. After delivery, they discharge and go back again after 3 weeks. Post delivery will be their first visit. Okay. Here, what are the things that you can get an opportunity to tell here is especially if there are women with a chronic hypertension or over diabetes or cardiovascular disease or depression, all these can be evaluated in this postpartum clinics that they have to visit. Okay. And they will also have an opportunity to counsel on their update on the immunization as well as counsel them for a postpartum contraceptive measures. Okay. So please remember there's something called the fourth trimester. I remembered with this. Okay. So fourth trimester is up to 12 weeks. This is a newer concept that has been updated in your Williams. Okay. So what are the risk factors? See, all this I'm not going to tell you. Okay. Anything stretching beyond its limit, like in a multiple gestation, macrosomia, polyhydramnios, that becomes one. Important this one, increasing maternal age, previous PPH becomes again a risk factor. Placenta previa, placental abruption, you know, any infection or prolonged labor, precipitate labor, preeclampsia, all these becomes a important risk factors for the development of PPH. Okay. And comes your medical steps. What will you do? You have to put yourself in a labor room situation and then answer your questions. These kind of questions you have to put yourself, especially labor questions. Okay. You try and massage and you'll ask them to give an oxytocin. Okay. First, you call for help in case of a PPH. Then you massage as well as start with all your therapeutic oxytocin. When I say therapeutic oxytocin, how much drop should be given? At what speed should be given? 60 drops per minute should be the speed that is set for your therapeutic. Okay. Next, you give an ergometrin provided you rule out all the side effects or contraindications like a preeclampsia, organic heart diseases. You rule out, then you can give a ergometrin 0.2 milligram per IM, or you can give a misoprostol, carboprost. Carboprost, again, very, very important. What is a contraindication? Asthma, pulmonary hypertension. Asthma is a very, very important thing that you have to remember. 250 microgram can be given up to 8 doses. And next you have to remember is your tranexamic acid. Tranexamic acid can be given in a dose of 1 gram in 100 ml NS given within 3 hours of hemorrhage. So this is one more important thing to remember. I have given all the drugs. I cannot wait. Okay. She's bleeding. She's pouring. What will you do? Go for your mechanical steps. Beckery balloon. Okay. Or condom. If it's in a PHC, if your question says the patient is in PHC and she's bleeding, I have to use something as a tamponade. Your first answer should be condom can be used. That is easily available. Or another one is your, what is another one? I'm talking about a PHC. PHC, I cannot ask for a Beckery balloon and all. What is another one that you can commonly use it in a PHCs? And they shift the patient to a main center. Condom, I told you. What are the other things? Blakemore, no. This is not easily available. Beckery balloon, Blakemore, Sengenston, Blakemore, all these. Foley's, yes. I want this answer. When I'm giving a scenario saying it's a PHC, please remember it's a Foley's and a condom catheter is the one that is available. With that, you have to shift the patient to a tertiary center. Then tertiary center, what extra they can do? Doing a compression sutures. What are the sutures you know? Belin sutures is a must you have to remember. Heyman suture, Cho sutures, okay? Okay, box sutures, all these are again a uterine compression. It's a basic concept is nothing but the anterior and posterior wall of the uterus is approximated. Thereby, the placental raw sites are closed or the sinuses are closed by this. Okay. Next is your another saving procedure is stepwise devascularization. But what you have to know is uterine artery ligation, internal iliac artery ligation. See, first is your uterine, then ovarian, then you have internal iliac artery. All these fail, still she bleeds, then nothing we are left with doing a subtotal hysterectomy. Other options using are the angiographic embolization, aortic compression with the help of a radiologist. It can be done, interventional radiology. But all these are time consuming. We might lose the patient. Okay. So this is how you have to remember the steps. Medical, mechanical, surgical, stepwise devascularization, nothing helped, go for a hysterectomy. This is what they expect from you. Okay. Another keep on asking questions is what are the causes for non-immune hydrops? Anti-shock garments, when and where? See, these kind of questions. On anti-shock garments, all these are used. Little more detail if you want, I will make another table and send you. This is how you approach for the question. Anti-shock garments, I'm not talking very, what do you say, extensive type of questions. These questions, yeah, where do you use in the sense? If it is usually used in a tertiary center, I can show you an image of that also. And they have a particular numbering system which they have to cover it. So this is mainly anti-shock garments. It's not, it's like covering the whole of the body with that. With the numbering system, you have how to cover. You have a image for that. I can send you that also. Read it once. It's not very important, but these are the newer techniques. If you have to say newer methods for PPH, that becomes a separate newer topic that is. Okay, that also I will make a small table. Ajay have asked it. I will send you that also. Okay. Another important table is non-immune hydrops. Certain tables are a must that you have to know. Non-immune hydrops, WHO classification for a heart disease, which is the heart condition that is contraindicated for pregnancy. That means that patients are directly denied. We directly tell the patient that please don't conceive or it's a contraindication. So the class 4 and class 3. Okay, basically the class 4 all the conditions you should know. Okay, even if you can't memorize the whole of the table, that's okay, absolutely fine. But please revise that table, at least the, where is a table? I made a table for you. Okay. So one such table is your non-immune hydrops fetalis. When I say immune hydrops, remember it is RH isoimmunized pregnancy. Okay, I had already given you, there is when to deliver, is it not? We had shared that also, when to deliver. For RH, there is always a confusion when to deliver the patient. See, for a non-immunized, where you have your ICT negative throughout her pregnancy, you deliver her at 40 weeks. If she is iso-immunized and she has not received any IUT and her critical titer is below critical titer, always her titers in ICT is below the critical titer, deliver even at 38 weeks. If she is more than the critical titer, deliver her 36 weeks. If she is iso-immunized and she is on IUT, we deliver 34 to 36 weeks, never prolong more than 36 weeks. Don't get confused for this. This is a often asked question. Okay. How long is the class today? 1 hour or how much is it? You already crossed 1 hour. Okay. See, your oncology part will be covered as a tabular format. What other topics you want? If people want, as it's a little difficult for me. Any other topics that you want me to take? Aneuploidy screening, yes, I told you that I will send you with, I want you to, I will be adding certain images that you have to know from your ultrasound part also. That also will combine it so that you people can read it immediately. Any other topics that you think it's difficult? Critical value, see, remember labor, yes, labor also I'm sending you. Labor management, I will send you in this part. One is your maternal pelvis, fetal pelvis, okay? What is abnormal labor criteria? Okay, WHO care guide. Okay, yes, labor stages and management. Yes, of course. Then breech, uterine prolapse, uterine anomalies. Okay, uterine anomalies, I have made it and said, okay, that was different. Okay, uterine prolapse with management. Okay, labor. See, labor, as I was telling you, maternal pelvis, fetal pelvis. What else you have to know is your breech, all the malpresentations and DTA, OP positions, okay, and abnormal labor, WHO care guide, outlet forceps. That's it. That's more than enough for your labor management. Okay, maneuvers in labor. That's what we'll combine everything. That least with images I will send you. Okay, that is for your quick revision. And uterine anomalies. Okay, uterine prolapse. Okay, labor, I'm already making it. Oncology, I'm making it. Okay. Critical titer is somebody is mentioning 1:16. It depends upon the center. That means which center they are doing. For some labs, it is 1:16. For some, it is 1:8. Different institutes have a different critical criteria. But remember, 1:16 is the criteria that you have to remember. Okay. That's what, sorry, something with my camera. Okay, what else? Instruments, okay. There is VSV. We have lot of things that we have discussed, image-based questions, is it not? So, that also you give a reading once. I think in that everything, most of the things are there. I didn't share anything actually now. Okay. So, please remember this kind of tables and certain tables. What are the changes in pregnancy? Physiological changes, cardiovascular, respiratory, renal, and blood. You should know properly. All these are last minute revision. And I made a table like this. How will you screen for? Yes, I'm making this table. Just started with this. Okay, this is also an anticipated question. Okay, aneuploidy screening. What is first trimester? What is for the second trimester? And how will you combine? My camera is not working, by the way. Okay, but my screen is visible, right? Hormonal cycles versus menstruation. Okay. I have noted down whatever else you want. Okay. Camera is creating problems. Yeah. Okay. Aneuploidy screening is also another anticipated question. Anything else? That's all. See, this is how we would go for a last minute revisions. So, oncology, labor, alert search. Okay. Okay. That's a simple thing. uh, I'll just give you, Nandini, I'll just give you a small one image that is going to explain you whole of your alert search, the estrogen peak, when you have a ovulation. Okay, that is an important question. Okay, not to worry, that I will send you photograph updates, and I will be sending you all the newer contraceptives, newer updates, newer you have to know the Anemia Mukt Bharat, which is a must. Okay, that also I'll be sharing. Just to read what is important from the obstetric point of view, not from PSM. I'm talking about what have they updated for a Anemia Mukt Bharat. So the certain guidelines and newer things that I will be updating to you. Okay. Anything else other than this? You have a see labor, oncology, and they've asked on Mullerian anomalies as a single chart, labor part, okay, and prolapse, okay, and certain tables, important charts that you have to know, okay. Everything we can send it like this kind of revision. Quickly, we will send it like this kind of a revision, okay. Read it once, and MTP guidelines regarding menstruation as well. MTP guidelines, they will ask you for the amendment only. Okay. Amendment, I just taught you. And basics, biophysical profile. Okay. Biophysical profile, you have to know about the Bishop scoring. These are the certain things that requires, before going to exam, you have to just read once. Okay. Apgar score. Bishops, Apgar scoring, biophysical profile. Okay, you have to just give a reading. Modified biophysical profile. Okay, write it down all this, read it once. Similarly, the chart of WHO. Okay, because these are in the end moment, you just read once, that's more than enough. You need not have to push yourself a lot of things. Just give one short reading, just to do 3 seconds. Okay. Your major concern will be of the onco and labor part. Okay, don't worry about that. That will be made it in a simple table. I've already started making it as a table. Who have not got the this one, I will send it to you. Okay, Apgar biophysical bishops, all the physiological changes, cardiovascular system, respiratory system, renal, blood. Okay, it's a must. Of many things, at least these 4 you have to know properly. Cardiovascular, respiratory, blood. Okay, write it down. Okay, this is important thing you have to know. Gynae, other than the onco part, other things are easier. Okay, WHO table for a cardiovascular system. Okay, the risk factor scoring. Okay, WHO. Anything else that you want? Aneuploidy screening is a must because it's very anticipated question this year. Because they want you to know basics of aneuploidy screening. Okay. And certain images, ultrasound images that you have to concentrate. I will be sending you that also. Just go through once. Any other doubts other than this? Okay. Thank you so much. Be confident. Okay. Don't think that I'm not completed my reading. See, somehow you have read somewhere, okay? If you're not knowing any question, please rule out options. Okay, don't lose hope by reading. I don't know, I didn't read this question. Don't lose hope by just seeing the question. Okay, wait, read. Even if you're not able to do after reading, also give some time, do it in the end. Okay, don't be thinking of one particular question. But one question is not going to decide your rank. Okay, concentrate on all type of questions. Don't think of completing. Try to read all the important topics before going. Okay, you'll definitely do well. All you have given your hard work, so definitely you will see the best results for you. Okay, thank you so much. Any difficulties, you can contact me. I'll be explaining. Okay, whichever you want. You have some more days left. Okay, thank you so much. All the very best.